Hey everybody. It's time for The Doctor is In. Hey Monique, hey Dr. Mo.
Hey, how we doing, everybody? Welcome to another episode of The Doctor is In. I'm Dr. Monique Gary. I am a breast surgical oncologist, a breast cancer surgeon in Pennsylvania. My co-host here, Ricky Fairley. Introduce
And
yourself.
I'm the CEO of Touch, the Black Breast Cancer Alliance. I just got new t-shirts today. How about that?
I love it.
All right, and check out my new mask.
Awesome.
We're gonna have these on our Facebook page for sale soon. So we love that.
There we go. We want to encourage everybody to share this on your pages, share it with the public. This is really, we hope it's relatable, reliable, and real information for our breasties, as well as our family members, caregivers, supporters, and anybody who cares about and knows anyone who's been affected by cancer in our communities. We're going to talk today about COVID-19, which is why we initially started this program. Yeah. It's called Hijacked by COVID-19. And we have got an amazing lineup for you today. Ricky, tell us who we have today, please.
Yeah, we have an incredible epidemiologist, and I'll let her give her own introduction. From Harvard Medical School and Mass General, Erica Weiner. And then two of my breasties, I love my breasties, my favorite breasties, Shantae Drakeford and Otta Cottrell. So I'll let them introduce themselves, everybody, and let's get started. Why don't you start, Dr. Warner?
Great. Yeah. Hi, everyone. I just want to start off by saying thank you for inviting me to this wonderful session. I've heard great things about it, and I'm happy to be here. So I'm Erica Warner. I am an epidemiologist who probably heard a lot about epidemiology lately because of the COVID-19 pandemic. Most of my research is about cancer, though, primarily breast cancer, and I'm very interested in studying what are the factors that cause women to develop breast cancer, why certain types of breast cancer are more common in Black women, and trying to understand what are interventions we can do to try and reduce the disparities that we observe in breast cancer risk and survival. So that's my passion. What I am here today to talk about is a study where we looked at how the COVID-19 pandemic has affected breast cancer care.
Great. And we believe that Black breast cancer is its own disease. So we so appreciate the work that you're doing, and we totally call it a different disease because of all of the things, because of the mortality rate and our devastating numbers. So thank you so much for being here. Thank you so much for being here.
Yeah, happy.
Shantae, my breastie, I love you.
Hello, everybody. My name is Shantae Drakeford. I am 36 years old, but at the age of 31, I was diagnosed with stage 4 metastatic breast cancer as my first diagnosis. I had metastatic mets that spread to my lungs, my hip, my spine, and my rib. And so since I am stage 4, treatment for me is lifelong, but I did have symptoms since I was 25. And I'll let you guys know more in detail later, but basically I was dismissed a few times about that.
Yeah, it's so typical of young women and young Black women. They go to the doctor, present with a lump, and get dismissed because they don't want to pay for the mammogram, they want to see you. They say come back in 6 months, and Shantae is a nurse practitioner, and she couldn't get to take her seriously in the health community. How crazy is that?
Ricky, it's deep though, because mammograms pick up density, the way an x-ray looks at a bone. So if you look at an x-ray, you see the thickest thing, which is the bone, but you don't see the muscle and the skin and all the soft, squishy stuff. Mammograms similarly pick up the densest thing. And young women notoriously have dense breasts. And the way that I explain it to my patients, it's like a natural sponge, not those cute little kitchen sponges, but like a real sponge. Some people have a lot of fibers and little tiny spaces, and some people have a lot of spaces and few fibers. African-American women, Black women tend to have more dense breasts. They have more fibers, and that makes it harder to see. So even the sensitivity of a mammogram is diminished for women who have really dense breasts. So you're talking, somebody who's 25, 26, who's 30, 31, your breast density is going to be really create a challenge in even picking up a breast cancer. And so a lot of times insurance won't cover it for these young women. And that's where we in the medical community have a lot of work to do, because somebody should have got an ultrasound, an MRI, other things.
Right.
And, we need to be advocating for our patients instead of saying, well, the rule book says, that we shouldn't do these things, and it's probably fibrocystic, it's probably whatever.
Yes.
That's where we go wrong as a community, I think. And we have to take every single, breast mass and breast complaint really seriously.
Right. And Black women under 35 are getting breast cancer at twice the rate. It's no joke. So we need to really pay more attention to that. And Ada. So Ada is a teacher in my mom's school. My mom was a principal. So that's how I know her, but she's a breastie now. I mean, I've known her without being a breastie. Now she's a breastie.
Yes. So I also felt a lump when I was 39, but I was officially diagnosed at the age of 40, stage 2, breast cancer, triple negative. And of course, the first person that I wanted to talk to was Ricky, because I know that she just knows so much. So I've appreciated it.
So yeah, we're glad you're doing great now. So you had your mastectomy right in April.
Oh, okay, yeah. So I had a double breast mastectomy in March the 19th, and
right before COVID, really, or right in the beginning, right?
Yeah.
Yeah. So ideally, I was supposed to have expanders in for a little bit of time, have my surgery. After my surgery, start a pill. However, COVID happened, so I'm still in my expanders, and there's no surgery date scheduled at all.
I think, and I think you called me about maybe in May and was asking about surgery. And so remember, Mo, I actually text Mo and I text Dr. Regina and I said, okay, so my breastie friend can't get her surgery, and both of you said, suck it up. There is no plastic surgery happening. And in the state of Maryland, Regina said the whole state had shut down all plastic surgery. So at least I think that
even shut down breast cancer surgery, Ricky. I'll tell you, I don't know who decided that breast cancer was elective surgery.
Thank you.
There were entire guidelines surrounding who could get surgery, who needed to go on neoadjuvant, which means medicine before surgery.
Yeah.
So patients who initially perhaps could have undergone certain surgeries were put on pills as a bridge to surgery, or placed on chemotherapy as a bridge to surgery during COVID. And so we have found that the entire treatment pathway, the path that patients usually take, has been detoured as a result of COVID. And that's something that we want to talk about and circle back with, because I think it speaks to Dr. Warner's research. When we look at the effects 5 years, 10 years from now, and what happened to women with regard to their screening, with regard to their diagnostics, I'm seeing patients who have more locally advanced disease, meaning it's in their breast, in their lymph nodes. They've had masses, they waited, and now things are more progressed. So we are seeing that, COVID really has, it's put a wrench in everything for a lot of patients.
So Dr. Warner, Erica, what does your research tell us? What'd you find out?
Yeah, so just to back up a little bit about why we did this study, it's definitely been touched on already here. Because of the COVID-19 pandemic, many institutions basically shut down all elective procedures, and that included screening, that included some surgeries, that included a wide variety of medical care. So in March 18th is actually when the guidance came out from the Centers for Medicaid and Medicare Services, also known as CMS. They're the ones who administer Medicaid and Medicare programs. And they basically said that as of that date, all elective procedures should be discontinued. And they stratified different types of care into like 3 levels. So essentially anything that was elective, they said, don't do it. And anything that potentially could lead to increased risk of death or harm to the patient if it was not done in a timely fashion should be, you should reconsider what the options are for doing that, receiving that type of care, delivering that type of care. If there was a way to do it remotely, they encouraged that. And if patients had to be brought in, they outlined some guidelines about how to protect both patients and staff. So sort of with that backdrop, knowing that there are recommendations coming from the federal government and lots of other organizations followed suit and made similar recommendations about shutting down different types of services. You know, as a breast cancer researcher, I was really interested to try and understand how that is affecting women who are trying to receive care, both people who have not been diagnosed with breast cancer and are trying to be screened so that they can have their cancer early detected. I was interested in people who potentially you know, have had an abnormal mammogram that needed follow-up, because that's a really important window that we try and focus on, keeping that time between an abnormal mammogram and the diagnostic procedure short. And then as well as individuals with breast cancer, you know, how it's impacting their treatment that they may have been scheduled to receive. So what we did is we worked with a lot of different organizations and basically fielded a survey that collected information from women. And and it wasn't just women, there actually were several men with breast cancer who did respond to the survey, and it was open. But I was really interested in getting information from people, from the individuals who were being affected, because I was seeing a lot of data that was coming out that was institutional level. So they were saying, what is the experience of a hospital? What is the data that we can get if we look across a big electronic medical record system? But I wanted people to be able to tell me about their experiences. And so that's why I did this survey and had great partners in it. And so essentially what we asked about was sort of where in the continuum of care the respondent was, from a person who's receiving routine mammograms, has never been diagnosed with breast cancer, to someone who's going through diagnostic evaluation, meaning that they have had an abnormal mammogram, or maybe they had a biopsy and they're waiting for a diagnosis, to a person who has been diagnosed with breast cancer. And then we asked about people, whether they were undergoing active treatment for their breast cancer, or whether they were in surveillance, meaning that they've completed active treatment and are being surveilled for potential recurrence. And we asked questions about the treatment they were scheduled to receive and whether that had been delayed and to what extent it had been delayed, rescheduled, or canceled. We asked information about their demographic characteristics, because, you know, one of the things that I'm always interested in is whether there are racial, ethnic, or socioeconomic disparities in terms of how something like this pandemic impacts people's care. And we also collected information about potential financial impacts of the COVID-19 pandemic, because as we know, there's been massive unemployment because our healthcare system is set up so that your health insurance is tied to your job. An individual losing their job or someone in their family losing their job could mean losing health insurance, which would affect their ability to receive care. And we also asked about, you know, worry and anxiety in general about the pandemic, and then specifically about whether the pandemic is affecting their ability to get health care, or for women with breast cancer, their ability to get treatment for their cancer. And I would say the big takeaways we came away with this is that, so we had 576 people complete the survey. So it was a fantastic response. About 20% of those respondents were identified as Black or African American, which was something important to me, that we got diversity in our responses. In what we found overall was that between 20 and 30%, depending upon whether you'd been diagnosed with breast cancer or not, reported that they'd experienced a delay of some sort in screening. So that included mammography, MRI, or ultrasound. And among individuals that said they had a history of breast cancer, about 10% said that they'd had a delay in their treatment. And that's everyone with breast cancer. So not everyone that had breast cancer was currently undergoing treatment. So if we restrict just to the people who said they're currently undergoing treatment, it was about 20% who said that they had some form of their care delayed as a result of the pandemic. So I thought that was, really important. There's been a number of studies, including from the National Cancer Institute, that came out recently that showed basically they projected what they think over the next decade the impact of delays in care due to the pandemic will have on deaths from breast cancer and colorectal cancer. And their projections right now say that there will be 10,000 excess deaths from breast and colorectal cancer because of delays. And so
Wow.
I think it's really
That's so like that information is very critical, and it's almost like bringing up my anxiety from when I was, basically delayed in essence. Like I remember the very day I had nipple discharge. My husband just came back from deployment. The very next day, my nipple started leaking yellow fluid. I went to the doctors immediately because I am one to try to catch anything I can early. They told me, oh, you have dilated breast ducts. It's fine. You have a fibrocystic, dense breast, like you said, Dr. Berry. And just come back. If it turns bloody, then we'll do something about it. It turned bloody. Then they gave me surgery. Then I started developing cyst that was a lump. It was soft. I had surgery, removed the breast duct, but that was still a delay. But they never would give me a mammogram. They never biopsied. And it still was like fearful for me. But then they said everything was still benign. 6 months later after surgery, they tell that soft cyst turned really hard, 8 centimeters, 8 centimeters, grew very rapid. I'm also triple positive, and I dealt with infertility prior. So I think that rampant the growth of the cancer cells. And then it started to spread. And by the time I found out, it was too late. And like, what diagnosed to be? An MRI. And it's just like they did a mammogram and they did an ultrasound, but it's like scary to know that you can't even get your MRI, your mammogram. You're sitting here worrying you have this lump. You go to your providers, oh, it's nothing I can do. Like that scares me. What if I would have waited just a little bit longer? It already started going in my lungs. Like it was spreading. They say they looked under the microscope and it was spreading so fast. Like, and I had like pain in my breast a little bit, and I had like some hip pain, but you always like think it's something else, but it wasn't like I was ignoring anything. It's just mind-boggling that the delay is scary. And I know those patients out there are very, very afraid. And I can empathize with that a lot.
It's true. And I know that hospitals initially put their own plans in place. Like I'm the director of the cancer program in my hospital. We sat down together and we said, okay, what are we going to do for patients? And we started to look at those patients who were in active treatment, those patients who were getting routine screening versus those patients who were getting diagnostic imaging. And I know for me, for my cancer patients, I ordered diagnostic imaging for the first 5 years following a diagnosis. So diagnostic imaging means someone is reading it right then and there. It is not considered an elective, you get your screening mammogram once a year. It means that they're going to look at it. If they need to do ultrasounds, they're going to do ultrasounds. It means that you get an extra level of attention, because I think that for that very reason, Shante, because of the anxiety, And so screenings were delayed, meaning if you didn't have a lump, and it was just your annual, you got pushed back because of COVID. But if you had diagnostic, we were still trying to fit those patients in, even if we could only get, 6 in the door a day, 10 a day, 4 a day. And for the patients who were feeling something, we were all virtual, except one day a week, I would go into my clinic and I would see patients in person who had issues like nipple discharge, issues like a mass and something found on imaging, they needed a biopsy. And so at least one day a week, we were trying to see those patients because, you know, cancer doesn't quarantine. That's my hashtag, hashtag cancer doesn't quarantine. And we needed to reassure those patients that they weren't just getting pushed aside because of this pandemic, because this virus is going to be around. But Dr. Warner, that number scared me. You said 10,000 projected deaths.
Yeah.
Wow.
Unnecessary deaths.
Unnecessary, yeah. Excess deaths.
Yeah.
Yeah. So I think that, you know, one of the things that I worry about is that there's so much variability across the country, right? And so, Dr. Gary, you're saying at your hospital, you were very thoughtful and planned very carefully about who needed to come in, how you were going to get them in, how you were going to sort of stratify people by risk, and then make sure the people who had the highest risk got the care that they needed. And I think that that's really important. I think that was part of the CMS guidelines, but it's not, you know, the devil's in the details. And we know that we have so much information that doesn't get applied correctly or equitably across communities and across institutions. And so, you know, that was part of the motivation of this study, to see how things are being implemented differently in different places. I think this number of 10,000 excess deaths, I mean, that's a projection, you know. I think there's still things that we can do to prevent that from coming to fruition, you know. So I think there's a lot of work that can be done in making people feel safe to come back, right? There's certainly a lot of anxiety. I mean, we know that the virus is still spreading rampant in many communities. So feeling anxious about going into a healthcare setting right now is completely normal, right? I feel it too. I should go in for my annual appointment, but I'm gonna, you know, try and do it virtual because I would rather not. But I think what the messaging that we need to put forward is really about who are the people, as you were saying, who are the people who really need to come in, right? The people that, in the absence of some medical intervention right now, could have a negative outcome that's potentially avoidable. You know, who are the lives that we can save with some action, some clear and decisive action right now. And so I think, like, as a medical community, that's what we have to be invested in. And really, I can't emphasize the importance of, like, clear messaging and really creating a culture and feeling of safety.
Yes, because if you're not, like, if you feel like you're, like, some people only try once, right? And once they're shut down, they're not going to come back. I work in an underserved community, and I try to get everything done as much as I can and try to stress the importance of it, because I fear they won't come for follow-up. And, you know, there's a disparity there. And then even just with the technology with COVID, not everyone has access to that, or even know how to use it, or have data, or have cell phones. And so that's a disparity, and that's a population we're not even reaching. You know what I mean?
But as people of color too, I think sometimes we feel like if we go in, we're not going to be believed anyway. So what's the point in even, you know, risking myself to go in? But I was chuckling a minute ago when you were mentioning about being careful and, you know, the steps you were putting in place in your office, because that's not my experience, you know, and not everybody gets that. I would have loved that, but, you know, there are people, like, I had my surgery March 19th, and the person who did my surgery still has never laid eyes on me. So, you know, not everyone gets that.
But you deserve it, though.
You deserve it. So Ada, tell your
does.
story a little bit. Tell about what happened with you and your surgery.
What happened with me and my well, it's kind of a long story because so when I had a primary care appointment in November when I was 39 years old, and I felt something. I was looking forward to that appointment because I wanted to say, hey, I felt something, you know. But I was told I have dense tissue. It's nothing. Literally 6 months later, I was turned 40 and my OBGYN found the lump. And, you know, by the time I actually confronted that, like, this was the truth, it was a significant lump. Like, it was definitely something that I should have known for sure, you know, but when you're told it's nothing, you literally believe it's nothing, even if you can feel it, you know? So I had a mammogram because I had just turned 40, 23 days earlier. And I was diagnosed at stage 2 breast cancer. I wanted to have a mastectomy, but I was told no. You know, like I got a second opinion. Both opinions were, well, you know, have chemo first, and then, you know, you can go through that. And then I did. I went through chemo. I had a double breast mastectomy. Come to find out, I didn't have a complete response to chemo. But there's various theories that I've heard regarding why. There could be scar tissue around it, so maybe the chemo wasn't getting to it or whatever. But in my mind, I was like, I wanted that mastectomy first, but whatever, you know. So you just kind of you just go with the flow. That's what I did. I went with the flow. I followed along, and there were complications, but because of COVID, I had to weigh whether or not I was going to be believed that there was something in my side. And I sent an email and talked to my doctor, but was told, nah, and finally reached out to an unrelated doctor, the actual breast surgeon, not the plastic surgeon, but the breast surgeon. And she spoke with me and said, if you think there's a stitch, it's there. And, you know, walk me through how to get it out. And so as of yet, I still haven't seen my plastic surgeon. But this week I'm taking consultations. I had my second one today.
Nice.
So I can, you know, go somewhere where I'm not afraid to say this is bothering me, because I believe if I say that, they're going to say, you know.
This breaks my heart. It does.
Wow.
I mean,
Yeah.
this is, and this is what's so scary right now about what's happening in this country with respect to information, or I'm going to say misinformation about COVID-19. So this novel coronavirus, right? You got these doctors parading around in these white coats, right? What are they called? The America's frontline doctors, right? Who are spreading misinformation, and it does not help the trust factor with our community. It does not help one single bit. And we have to work so hard to try to even just get women to come in to believe, you know, in some of the treatments. And I understand why, but that trust just has to be repaired. I mean, I'm dedicating my entire life's mission to bridging that trust, because it's broken. And, you know, I'm not the doctor that did it, but I'm part of the community of doctors that did it, you know, and that are continuing to do it. And we have to speak up. We can't just say, oh, well, somebody else will get to it, or eventually they'll see the truth. You know, it's not true. We have to be the change. Somebody said that earlier on this call. We got to be the change.
Yeah.
Right. Well, also, I don't think coronavirus is going to go away. I mean, my opinion, I'm not a doctor. I don't
Not
know.
in this country.
It's not going to go away because of the behavior of our country. People are not wearing masks, and they're not doing the right thing, and they're spreading the disease like crazy. So I think we're all going to have to find a new normal, and we can't stop breast cancer treatment and prevention tactics. We just can't. We have to figure out, you know, you can't miss your mammogram. And even you, Erica, you need to go get that thing. You know what I mean? Like, I keep encouraging people. So I think we have to,
Not old enough.
I know you will. I know you will. I'll call you.
I am. You can be my accountability buddy. I'm due for mine. Everybody watching. I
No,
don't know
don't even get me
watching.
started. Don't even get me started because I will come and get you and take you there.
I love it. I love it. I'm due for mine. I will get it. I will proudly report back to all of you because, you know, I have family history. My grandmother had breast cancer, bilateral breast cancer. And, you know, my mother had ovarian cancer at 29. So I am at that intersection of high risk myself. I want to circle back to something you said, Dr. Warner, about the data that you were giving and the way in which you collected it. So you collected survey data. And this is something I want patients and people who are watching to realize, you know, there is this concept of real world evidence or real world data, right? And trials take on all forms. So they're not always drug trials. And I want you to speak to the importance of information that we get from patient reported data and how that can impact care faster than the study that's going to take 10 years to complete. You know, like talk a little bit about that type of research and why it's so important for people to participate in it.
Yeah, it's crucial. I mean, I think it's so important to hear the voices of patients and the people we're trying to serve. I think, you know, for me personally, and I know other scientists feel the same way, we get so much insight, you know, in terms of, are we even asking the right question? Are we asking the right question of the right people? I may have an idea of what I think is the root cause, but hearing from your experiences, I can learn that, well, actually, there's a big issue with just being believed, right? And that may be an important place to try and create interventions. I think sometimes it helps us illuminate the role of healthcare providers and the healthcare system in creating the disparities we observe. So it's super important. And it's, you know, the research that it's important to participate in is, like you're saying, across the spectrum. So, you know, we hear a lot about clinical trials and they are crucial. I have projects where we're trying to work on how do we increase minority enrollment in cancer clinical trials. But beyond that, you know, there is a lot of just sort of what we call population-based research, where we're asking people questions and we're sort of following them up over time to try and understand how different factors relate to the outcomes that they had, you know, how well they did with their breast cancer or their emotional state, you know, worry, anxiety, these types of things that have come up here today and are part of my own research. So it's really crucial that people participate in that type of research and that it's representative, you know. As a Black woman, I am always trying to get more Black voices included in the research that we do, because there are differences in our experiences, right? And if it's not captured in the data, it's much easier for people to ignore it. And so I'm always about centering Black voices and putting the experiences front and center.
Yes, I think that's important. And just revisiting the data and going back, even though like the data has been finalized, but just going back and targeting a specific population. Like for instance, one of the medications I take, I saw an article probably like a few months ago that displayed that African-American women on this medicine has a high increase of being neutropenic, meaning like a low immune system, low white blood cell counts and absolute neutrophil counts. And I was always wondering like why I had to keep getting dose reduced. Like I'm thriving on the medication. It's shrinking everything down, it's keeping everything at bay, but I am literally at risk of getting off it because of the neutropenia. But that article I showed to my provider, I was like, this explains exactly why, for me in my instance, that I'm so neutropenic and has such low immune system. So I think it's important. And just even, you know, visiting like the IRB boards, the institutional review boards, I think that's important in representation and getting the information to them. because that impacts greatly on research. Sure.
I don't know if people watching know the power of what you just said. So
Right.
the IRB, the Institutional Review Board, is the committee that decides what research projects are able to move forward in a hospital or a university or an academic setting, even in community settings. So I'm the chair of the IRB in my hospital, and we always have a person from the community on that committee, on that board. And so if you're watching and you're interested in, finding your voice and learning more about research, there may be opportunities for you in your local hospital, within your university systems, to participate and to be an advocate and a layperson. You don't have to understand research, because it's important that you don't, so that they can make sure that every document that's put forward, all the consent forms and everything, should be at a sixth grade reading level, so that people can understand what the trial is and what it's about. And so if you're watching and you're kind of thinking about research and how you can get involved and maybe wanting to give back, our committee meets once a month. Most committees meet every other month, sometimes more frequently, but you can participate in that way. And you don't have to be a researcher, and you don't have to know anything about research. You have to express an interest.
Yeah,
That's great.
that's very
Can you
important.
explain neutropenia too, that Shante mentioned?
For me,
Yeah, or Dr. Gary, Doc, whatever. You can explain it, Shante. Go for it.
Yep, she's a healthcare provider. Got it.
okay, so neutropenia is basically, you get your lab work and we're looking at different things. One of them is your white blood cell counts and your neutrophil count. These are important for your immune system and how you fight disease, like anything that invades you. Like that's why we are a high risk population of COVID, because if we were to get the virus and we are considered neutropenic, meaning our immune system is very low, it is hard for our body to repair itself and to heal itself, and it's very weakened. So just think of like a little scrimpy little cell, and you don't have a lot of them, but you need a lot. In a normal person, with absolute neutrophil count, I think typical normal is 2,000 to 5,000, and for people with cancer, they want you to stay at least 1,000. At least that's my goal with my provider. I've been down to at least 500.
Mm-hmm.
And then I have to get my medication help, because if I keep getting this drug that's beating down my immune system, I won't heal. And any little thing that get in me, I can really get severely ill. And so it's hard to fight off. So neutropenia just means like a low immune system to fight.
Great.
That's a really, really important point.
Yeah.
Go ahead,
How
Rachel.
has your treatment changed because of COVID, Shante?
So luckily I've been able to still consistently go. I am, stage 4. So my treatment is lifelong. There's no stopping, there's no delay. So because I only have to go in once a month. So I go in once a month, and if anything in between, I could just need to discuss with my provider. I could just call and do telemedicine that way, but I always have to go in anyway and get my labs drawn and then get my treatment every 4 weeks at the hospital. But it hasn't really changed too much.
Are you scared?
Yes, every time I go into the hospital, I'm scared of people exposure. The place I get treatment is very good, but they ask you those questions when you come in. Do you have those symptoms? Anybody could just say no. And I might be sitting in a pharmacy. It happened once. I was sitting in a pharmacy and someone like right across from me was like coughing. I'm freaking out. I'm like, is this cough like coronavirus? I'm afraid, so I got like the hand sanitizer. I don't even get on the elevator. Like I walk up the steps because I don't want to touch the button and I don't want to be in a close vicinity of anyone. So yes, fear has increased for sure. I don't feel as comfortable, and I can't have a person who, like when I go for my scans, I go for scans every 3 months. I can't take anyone with me inside. Mm-hmm. So my support, I'm like alone when I get treatment. Good thing I have a good rapport with my nurses. They're like family because I've been going there for 5 years. But like someone who's new, I can only imagine that loneliness that you feel. You need that support. It's very vital, especially in the beginning. Radiation, you go there every day, and I can't have my person with me. Like, yeah.
Yeah. What advice do you have for people who are facing a new diagnosis and they're feeling that fear and they may not be able to bring their people either? What can you tell them?
I'm a big person on utilizing your resources and just, even if you just Google cancer support group or anything, go on Facebook. There's so many groups out here. You can't do this alone. Like, do not try, do not attempt. Ask people, my everything on my social media is open. I am an open book. You could private message me. I will answer anything that can to help you. Like, being quiet will not help. I just think that utilizing your resources. These organizations are created for a reason. Even if you just know,
Right.
Susan G. Komen, just anything. Okay. Yeah.
Yeah, call us at Touch. We'll help you. We'll get you somebody.
Mm-hmm.
You will get a. That's what we
Absolutely.
do. We'll try to
Anybody.
find you a mentor of. We'll get Shantae on the phone, out on the phone, whoever we need to get to help you
Yeah.
through, because it's so
You can
important.
FaceTime.
No one fights alone. No one fights this
No.
alone. Yeah. Yeah.
I
Anna,
gotta
are you scared? Like, are you scared to go? Like, are you done with your
Yeah,
chemo now?
I'm
You're
on a
looking for
pill
new
now.
docs, right? You're looking for new docs, right? You're getting different opinions.
Right now, I'm looking for a new plastic surgeon. I'm keeping my oncologist. I'm on capecitabine. I have another round and a half to go. I should be done around September, or late August, really. And then hopefully be able to schedule a surgery. Both surgeons that I've spoken to say that they're scheduling surgeries. So, you know, that's one of those things where I was like, I don't have to stand for this treatment. You can go somewhere else.
That's
But
right.
yeah, I had an incident today where like I voluntarily went to pick up my medicine, but there were people crowding up the doorway. My anxiety is already on 10. Then I get inside and I see one of the people in the back that's preparing the medicine had his mask, but wasn't his nose wasn't in it. I was like, I am out. I just left.
Yeah.
But I also think that, it's hard to find a balance, like, am I freaking out, or, is am I just being cautious? Because also due to COVID, I haven't been able to go in and have any tests done to say you are definitely clear. You are definitely, and I know that there isn't really a test that's going to say you are completely cancer free. But as of right now, like I'm saying, yes, I'm cancer free because I had the surgery and the cancer was removed, but I have no proof or evidence.
Mm.
Talk to us about picking a doctor and what you think some people watching should know about, selecting surgeons, selecting oncologists, and anybody can weigh in here. But people watching, need biopsies, they feel masses, they got imaging, they're trying to figure out what they should do. They have loved ones who need a second opinion because they feel like their mothers and so forth are getting pushed to the wayside. How do you pick a good doc, and how do you know what's a good fit, and when is it not?
I don't know how to find a good doctor. I have a lot of stress around that myself. But I think what you were just saying made me think about something too. Like, I don't know what the right thing to do is. I don't know when you're listening to your doctor and something doesn't sound right, you don't know if you should just shut up and go along or if you should call them on it. Like, you don't know what to do. You go home and you brush away all your worries because you're told to brush away all your worries. And when you go to a new doctor, you have a high hope. And then later on down the line, you find similar patterns starting to happen. So, like, I don't have any advice about finding a doctor, but I will say that through this process, there have been times where I was really sure about something. And, you know, I ignored myself and later on learned it was the wrong thing to do. And I will say that in this process, you will have those moments, like we all have those moments, all of us do, but your doctors can't hear your gut. Like, they don't know how sure you are. And so you just have to it's like exposure therapy. Like, keep speaking up, and yeah, you will be uncomfortable, yes, but the more you keep doing it, the less uncomfortable you will be, because you have to advocate for that gut. That's all I can say about finding a doctor, because I'm still
Yeah.
myself.
That's huge. Preach.
Yeah,
Yeah, great.
powerful.
You gotta nag. You gotta be a nag. You know how they always say, don't nag your spouse, but you need to nag your provider. Nag, nag, nag until they get tired of you and do something about it. That's how I feel.
Yeah, it's a thin line between motivation and harassment, right?
You know what though? I mean, I gotta say that I'd rather have the patient who comes in with pages and pages of questions
Yeah.
than the patient who comes in and just says,
Mm-hmm.
and then they walk out and you know that they have no idea what happened, what's going to happen to them. They're not an active participant in their health. And like this is, I don't do anything for patients. I partner with patients. And
Yes.
so I always start with, whenever I walk into the room, what do you understand about what's going on? And let you
Yes.
talk first. You explain where you are, and then we go back and fill in the gaps, because what we say and what you hear can be two totally different things. And patients will come back and say, well, I was never told this or I was never told that. But the eyes can't see what the mind doesn't know, right? So if you didn't understand it, then we gotta disconnect there. And so making sure that you ask those questions. Do not be afraid. Do not be afraid. And any doctor who gets offended by you asking questions, any doctor who gets offended by you getting a second opinion is not the doctor for you.
Doctor for you. No,
Period.
no,
I
no.
never get offended. If I reach the limits of what I know, I tell patients, listen, if I reach the end of what I know, and if I were your family member sitting in the seat advocating for you, and I would get a second opinion for my sister, I will tell you, you should get a second opinion on this.
Yeah.
Because, right. I mean, we have to do that. We got to be our sister's keepers,
Yeah.
And that not every provider is perfect, and it's different levels. So
Right.
definitely.
And everybody's busy and they're, they could be having a bad day that day. You don't really know. So Dr. Erica, what else did you learn? Anything else that we should be talking about that you learned from the survey, or anything we think we should be doing because of what you learned?
Yeah, a couple of points. One thing to note about the survey is that this is an ongoing pandemic. So we did this survey, it was open between like mid-May and mid-July. So it's just a snapshot, and really it only captures people who happen to have an appointment scheduled sometime between March and July, right? And so as this pandemic continues, more and more people are going to have an opportunity to be impacted by it. And so that's part of what I wanted to do, is sort of learn what's going on and how it's affecting people and what people are experiencing. So maybe we could learn how to do better as we go through waves of this pandemic progressing. Some of the things that have been talked about in terms of the personal experiences that have been related, I think we saw some evidence of that in the survey as well. So we asked about, among women with breast cancer, the extent to which they felt like they were particularly vulnerable to the negative impact of COVID-19. So like if they were to get infected, did they feel like they were at risk of, particularly at risk of bad outcomes because of their breast cancer? And we had something like 30% of people strongly agreed to that. So we also asked people about information sources. So there's been a couple of times where, conversations with providers and use of telemedicine has come up. We assessed that in the survey. We found about 50% of women with breast cancer said that they'd had some contact with a healthcare provider via telemedicine during this pandemic period. It was about 30% among people who had not, who did not have breast cancer.
How do you find that? Do you think was that surprising to you, or?
I actually thought it was a little surprising to me that it was 50%, and the women with breast cancer is high. Yeah, it was higher than I thought. So, I think this, the sample of people that took our survey, it's not a population-based survey. It's not necessarily representative of all women in the United States. Like, for example, about 60% of the women who took their survey had a college degree or greater, which we know is not the US population. So some of these may be different if you were looking in different populations, but I think some of the take-home messages resonate across. So we also asked about worry about progression. So concern that because of the pandemic, that delays in healthcare would lead to disease progression. And we definitely saw that, particularly for individuals that were on active treatment.
Wow.
Yeah. We also, I think earlier I mentioned that we asked about like financial impacts of the pandemic. So we did have people that reported either loss of their own job or loss of someone in their household losing their job. Some people had lost insurance as a result of the pandemic and had concerns. We asked them to sort of project their concerns about the financial impact of the pandemic on their future ability to get healthcare, and we saw that as well. So I think that there is, there's a lot of worry and anxiety about this situation, both in general, just the pandemic, right? It's very scary. There's a lot of unknowns, right? Yeah. And then that is, I think, compounded when you put that together with having a personal history of breast cancer, being currently treated for breast cancer, worried that maybe you have breast cancer and you need it to be diagnosed. So I think there's a lot to learn and a lot that we can do to try and help address some of these findings.
Right. So if I had a lump today, felt a lump, you guys, what do I do? I feel a lump, it doesn't feel normal. What do I do?
Call your doctor, get diagnostic imaging. Diagnostic imaging is still available in pretty much every city across the country, despite COVID, because it is for people who feel a problem, people who have an issue, and then try to get seen. Don't say, oh, I'm due for my screening mammogram in 2 weeks or my whatever, because your screening mammogram may be delayed depending on what state you're in. If you feel something, have nipple discharge, skin changes, nipple inversion, something doesn't look right, you need diagnostic imaging. So knowing the difference between those two is really important right now, because in some places we're starting to move a little bit backwards in some states. And so screenings again might be delayed. So if you feel something, see something, say something.
Should I accept a telemedicine visit? Like if my doc says, well, I'm not taking any patients right now, can we do telemedicine? If I feel a lump, what should I do?
So if it's a visit to get a script to get your mammogram, that is a little bit more okay, because your mammo, then you can look and see and kind of continue with that workup and circle back in person with the doctor. But ideally you'd want to be seen in person. A virtual visit is better than no visit at all. And so if they won't order a mammogram for you, let's say you're under the age of 40, or, you just had your mammogram or something and they need to see you face to face in order to understand what's going on. I'm finding that virtual visits allow me to listen to my patients better, because nobody's typing and doing all the things. And so they're not all bad, but the exam can't be done. So let's say you got your imaging, it didn't show anything, right? Then you need to see somebody, because somebody needs to feel your breast to see what you feel and to correlate your negative imaging with that breast exam. So I think it's more important to see somebody after the imaging almost.
Right.
Yeah.
And we should be doing our self exams. And you guys, if you follow me on Twitter, I will remind you every month to check your breast, check the breast that you love. I know you have a pair. So, I'll keep reminding you to do that, because we have to check ourselves. That, we can't prevent breast cancer, but we can really detect it. And we have to know our normal. So feel your breasts, touch them, know your body,
Hashtag check your chest. I got a check your chest hashtag, check your mammaries, call them whatever you want, but everybody has at least 2. And so sometimes more. So you gotta feel them. I want to circle back to these, projected deaths. I'm still blown away by this.
Yeah.
So, Dr. Warner, you said that, in a decade, we're projecting a mortality from breast and colorectal cancer, 10,000 excess deaths. And so I just did a little research, right? The number of mammograms that we need, screening mammograms, because the number one symptom of breast cancer is no symptom at all.
Yeah.
The majority of breast cancers are found on screening, right? So if this pandemic goes on and on and on, and screening gets delayed, how many women are going to be affected, right? So we need 84 women to be screened between the ages of 40 and 84 to save one life from breast cancer. For every 84 mammograms, right? One life gets saved. And so I need for people to look at the timing of their screening, and now's a really good window. If you are living in most states, with the exception of Texas, Arizona, Florida, where else is it getting bad?
California, yeah.
California, right. If you're in the other states where your numbers continue to trend down, now's a good time. Get your colonoscopy, get your mammograms, get in and get those things. Don't just say, oh, I'll put it off another, because the majority of cancers are detected on screening imaging 3 to 5 years faster than you would feel them. That's the benefit of mammograms. That's why they work, because they detect cancers sooner than you would feel them, sooner than ultrasound, sooner than thermograms, sooner than whatever else the latest, imaging is. So getting a screening mammogram and not being afraid to do that, or being afraid and doing it anyway, is probably one of the best things that you can do this year. So if you are due, if you are past due, like I am, we will be accountability buddies, and we're going to get our screening mammograms, because it could very easily save our lives.
Yes, that's important. I have to get my screening colonoscopy because I have a genetic trait for colon cancer. And they've been delaying that too, but I have to put my cancer diagnosis in the forefront to kind of make it more expedited. Yep, I totally agree.
The other thing I wanted to say in closing is that when you said, you weren't sure where to go to get information to verify what was correct, there are guidelines that doctors use. And the number one guideline that we use is called the NCCN, National Comprehensive Cancer Network, nccn.org. And if you go to that website and you type in the type of cancer you have, you will get all of the decision trees that doctors follow, so that you can know what comes next. And you'll understand why, if you have stage 0 cancer, you don't necessarily get a PET scan, right? Or if you have this stage, why they recommend these things, go to surgery first, go to do these things. And so there's a website that you can go to, so you can know what that doctor is going to kind of say to you, so you can then verify, and you don't feel like you have to just trust blindly what the doctor's saying. You can see it for yourself, or you can ask the doctor to pull it up and show it, and they should be able to pull it up on a computer and say, okay, here's where you are, here's what tests we should do, here's what treatment you need, and go from there. But I want patients to be empowered to know that it's not magic. It's very carefully thought out treatment algorithms, and COVID is kind of messing with some of them right now, but your doctor should be able to show you evidence of why they're choosing what they're offering you.
Yeah, and they have released some updated algorithms for COVID-19. So to help you understand sort of what types of changes you might expect and what's reasonable and what's not reasonable, that information I think is available. There was a New England Journal of Medicine article that covered it recently. I'm happy to share.
If you send that to us, we'll post it on our page and give that information out. And
we'll
also
put in the comments here too.
Yeah, great. If you need help with questions to ask your doctor, reach out to us at Touch BBCA, and we will we'll help you. We kind of walk through what you need to ask your doctor. Ada, you're smiling. What you're laughing, and what are you laughing about?
I'm just proud of you.
We have to do this work. I say it all the time. We've got to solve for Black breast cancer. We have to fix it, you guys. And so I so appreciate you going. I so appreciate you, Dr. Warner, coming on and doing the study. And and if you want to do more studies, we'll help you do that. And I do want to talk to you about clinical trials. I'm going to call you about that, because we've been talking a lot about clinical trials and try to understand that dynamic a little better. And it's so funny, Monique and I, every day we say, okay, what are we going to talk about? And every day we have things to talk about. It's like never ending. So we're going to keep doing it. We're going to keep talking. We're going to keep doing it. We're going to try to keep bringing information. And,
we hope it's relatable, reliable, and real, like us.
Yes.
And we thank you guys for watching. I think we're going to log off. Do we want to do some quick social media, how we can follow you things if people have questions, and then we usually go to the chat and we will actually respond to a lot of the questions and
Yeah, we
comments
have
in the
a
chat.
lot of questions in the chat. We'll
Yeah.
we'll answer all the questions that we can, you guys, for sure. But
Mhm.
Shantae, how can we reach you, babe?
You can mainly find me on Instagram. That's where I mainly hang out at Shante19. SHONTE19.
Perfect.
Ada?
I'm just a regular old person, so I don't know. I
Come
don't
for me to find her. If you want her, I'll get her for you, right? I'll get her for you. Dr. Warner?
Yeah, I'm ewarner_12 on Twitter. I'm very active on Twitter, so
Good, you can
find me
teach
there.
me.
So we'll put that in the comments. And you know how to find me at Ricky Dove at Touch BBCA on our website, touchbbca.org. We're here and we're ready to talk about anything, anytime.
Yeah,
And Dr.
Dr.
Mo?
Monique Gary on Instagram, the Facebook, the LinkedIn, and Twitter. And apparently I got a new YouTube page too.
Uh-oh.
Those are videos.
I subscribed.
You can find me there, and I'm happy to answer questions if I can. I'm not your personal position, but if I can give you some advice or point you in the right direction, I'm happy to do it, because you know we got to look out for each other through the pandemic and beyond. You know,
we do. So thank you guys so much, and you know, guys, come back, Dr. Warner, when you have more stuff. Come back, we'll talk some more, and we'll work on this Black breast cancer thing.
Yeah.
Hashtag BSD, much work to do, right?
Always.
work to do.
Resty
Thank
love.
you guys.
Resty love.
Bye-bye.
Yep, resty
Take care.
love.
know.
Bye.